Good evening, my dear respected speakers and panelists. They are sharing with us this webinars and give us their time to participate and give their information and experience, share it with all participants. They are going to be with us. I would like also to thank Alimera for sponsoring this meeting, and thanks Marvision for managing this event. I would like also to thank all participants. They are with us now, and we'd like to welcome all of them. We are having today 2 sessions, and this is new in our way of dealing with webinars. One session, it will be about retina, and we are having Dr. Ramin, and we are having Dr. Arif Adunwala. They will going to talk about the update in diabetic macular edema treatment and management. And we are having as panelists in this session, Dr. Prasan Rao and Dr. Ahmed Al-Barqi. They are a well-known vitreoretinal surgeon in UAE. In the second session, we are going to have 2 speakers, my dear friends and brothers, and we can say big brothers, Dr. Ala Al-Zawawi, that we are glad to have him with us today. He will share with us his experience. He's having a long experience, and he is a well-known international speaker worldwide. The other things, which is a something new, very interesting, something very really, I'm glad that it is the first place that we are going to share the experience and new techniques shared by Dr. Imad Musallam. He is a vitreoretinal and anterior segment surgeon, and he will show something very interesting. So we are encouraging everyone to be with us and see these new techniques in phacoemulsifications. In this session, we will have panelists, my dear friends and brother, Dr. Safwan Al-Bayati. He is a well-known anterior segment refractive and cataract surgeon, and he is doing also vitreoretinal, but the main concern of him is refractive and cataract. So thank you for all. And we'd like to start our meetings by having dear Dr. Ramin. He is a vitreoretinal surgeon, consultant, head of ophthalmology department. He is from Heidelberg University, Germany. So thank you, Dr. Ramin, and let us start with you. Thank you.
Yeah, thank you very much for the invitation. And now we have to get that started. Yeah, maybe you can just confirm if you are seeing the slides.
Yes, yeah, we can see the slide, please. Yes.
Okay, so yeah, it's really a pleasure that you invited me for this online meeting. Yeah, about 1 year ago, I actually I went to a meeting in the Middle East, and I was really amazed by the hot weather, yeah, that you are having in your country. So this time it's a little bit sad for me to sit here in Germany in colder weather, yeah, and give this lecture to you. But it's still really a big pleasure for me to talk about the real life long-term outcomes for patients that we have treated with the Eluvium intravitreal implant for diabetic macular edema. And I would like to share with you the 3-year follow-up from the IRIS study. So these would be the relevant financial disclosures. And I would like to share with you the results from the IRIS study. The IRIS study is an ongoing multi-center open label observational study. And in this study, we looked at the real world data on the safety as well as the effectiveness of the Eluvium implant in patients that we have treated according to the European label requirements. This means that all patients that we treated were treated for chronic diabetic macular edema, which had not been responding well to other treatment options. We assessed the patients over a follow-up of up to 36 months, and we looked at various outcomes. We obviously assessed visual acuity. We looked at intraocular pressure and IOP events because it's a steroid that we are applying in these patients. And we also looked at the information on additional DME treatments. I would like to share with you the 3-year follow-up data of about 343 eyes from 295 patients. And we recruited all these patients from 29 sites in the UK, 9 in Germany, and 3 in Portugal. So let's first have a look at the baseline characteristics. I think it's very important to have a look at these characteristics because I'm talking in my talk about a real-world study, which means that all patients who suffered from chronic DME could be included in that study. There were no real inclusion or exclusion criteria. Even if a patient had very, very poor vision, the patient could be included in that trial, and I think that's very important to keep in mind. We did not really select the positive patients for this trial. You can see when you look at the duration of the DME that patients in mean suffered from diabetic macular edema for already 5 years. So we quite lately started therapy in these patients with the Eluvium implant. The majority of patients was pseudophakic, which is important when we are talking about a steroid drug. You can see that mean visual acuity was quite low with a mean of 52 letters that patients had when we started treatment. When we look at previous treatment, you can see that basically almost all patients had been treated quite extensively with laser or intravitreal treatments. Most of the time, patients had received intravitreal agents. And once again, to remind you that this is a real-world study where only patients were included who have not responded well to other therapeutic options. Despite the fact that we only included patients who did not respond well to other therapy, 51.3% of the Eluvium treated eyes did not receive any additional treatment during the 36 months follow-up. We did apply a retreatment in Eluvium in several cases, but this was only required quite rarely and only after 2.8 years. So the manufacturer usually tells us that this drug is working for about 3 years. And also in real world, we really reach this long effect in a real world setting. So let's now have a look at the safety outcomes. Obviously, IOP can be a concern when looking at corticosteroids, but when looking at the mean IOP, you can nicely see that it remained within the normal range throughout the 36 months follow-up period. We only did notice a mean change in IOP at month 36 of about 1.2 millimeters of mercury. We did, however, notice that about 40% of the eyes showed an IOP increase, but in most of the cases, it could be handled quite easily using just IOP lowering drugs, eye drops in most of the cases. We noticed an IOP increase of more than 10 millimeters of mercury in only 16% of the eyes, and an IOP of more than 30 millimeters of mercury also in about 17% of the eyes. What is very important to look at is the rate of patients who required surgical intervention. And you can see that surgical interventions such as trabeculoplasty or incisional IOP lowering surgery was only very rarely required. Let's now have a look at visual acuity outcomes, once again over very long follow-up of 36 months. On the left-hand side, you see the number of eyes, the proportion of eyes who achieved a visual acuity of 6/12, 20/40 or better. And this visual acuity is so important because it shows you, because it's the vision that you need to drive a car. And you can see that about 19% of the eyes reached that level at baseline, and at month 36, 32% of the eyes reached that level. So you can nicely see that vision increases quite quickly and then remains stable over the course of the follow-up. We noticed that 71% of the eyes had a stable or even improved vision over a 36 months period. We also assessed if baseline visual acuity does have an effect on the vision outcomes. You can see that on this chart, we only looked at the eyes who had quite a good vision at baseline. We looked only at patients who had a vision of a 6/12 or better at baseline. And you can see that in such patients, there was no statistically significant change in visual acuity from baseline for any visit during the 36 months follow-up period. And I think it's very important to see from that slide that it makes a lot of sense to rather treat patients quite early, because in such patients, it's very important to still keep that good vision over the course of the follow-up. So in conclusion, for all patients who completed the 3-year follow-up, we could nicely show that the real-life outcomes could confirm the long-term safety as well as the effectiveness of the Eluvium implant in the treatment of diabetic macular edema after 3 years of treatment. And this was the case in a cohort of patients much larger than the EU registration trial population. The results from clinical practice could also show changes in IOP and visual acuity, very similar to those reported in the pivotal FAME trials. And I think that this is very important to address once again, that I showed you results of a real-world study, and it's not very often to see that real-world studies really confirm what we have seen in pivotal trials. If you look at the excellent results for anti-VEGF agents in the pivotal trials, and then have a look at the real-world studies, you will actually see that in real world, the results that we can unfortunately achieve with anti-VEGF agents are far worse than what we can achieve in pivotal trials. Earlier treatment of patients before the onset of significant visual impairment definitely makes a lot of sense because it can stabilize vision for up to 3 years. Thank you very much.
Thank you very much for this excellent presentation. If there is any questions from dear friends here, Dr. Ahmed, Dr. Hassan, to Dr. Before that, if they allow me, please, we have 3 raised hands, Dr. Khalid Al-Tayyib and Dr. Abdul Ghani Tertaj and Dr. Maryam Al-Shehi. So, Mr. Wayne, if you can have anyone at any time, and meanwhile, we are going to talk with Dr. Ahmed and Dr. Brasan if there is any questions or comments.
Okay. Yeah, thank you, Dr. Raman, for your excellent presentation. I just want to ask you about your real experience with Eluvium regarding the top-up. If you because you said most of your patients, this IRIS study, they don't receive any required any additional treatment or top-up treatment with anti-VEGF during 36 months. So in your real practice, so if you inject Eluvium in one patient and it was stable, and you find some increase in the central macular thickness and mirrored with drop of vision, how long you wait until you decide to top up? Because in some meeting, I found some doctors start top up after 3 months from Eluvium. So do you think it's quite early? What's your practice at this point?
Yeah, I think it's a very important issue that you are addressing, because something that you have to keep in mind if you are comparing the Eluvium, for example, with the Ozurdex. The Ozurdex is a very high load of steroid, and you will very quickly see an effect. In the Eluvium, that's a little bit different. It's a very slowly releasing device, and you see a very low release of the drug over a long term. So whenever you're injecting the drug, you sometimes have to be a little bit more patient. Don't give up if you after 4 weeks do not really see a perfect result. That sometimes takes a little bit longer in that patient, and I would definitely say when I give the Eluvium, I would wait at least 2 months until I start with additional treatment. Nevertheless, I also don't mind to top up treatment because once again I have to emphasize that all the patients did not really respond well to other therapies. So we are not looking at perfect candidates, we are looking at candidates who have not responded well to other therapies. And whenever I can achieve a good result with Eluvium plus another agent, it's still a good result for the patient. So I don't mind to top up the Eluvium. And what we usually do is if we top up, we usually apply an anti-VEGF agent. We don't go with another steroid.
Yeah, sure. Yeah.
Thank you, Dr. Raman and Dr. Ahmed. Can we have Dr. Khalid Al-Tayyib? Dr. Khalid, can you unmute yourself or unmute by Mr. Wayne? Or Dr. Abdul Ghani, he is with us. Also, he can start. Abdul Ghani. Dr. Abdul Ghani, if you can hear us.
Hello?
Yeah, تفضل. دكتور خالد تفضل.
دكتور خالد, السلام عليكم.
عليكم السلام على دكتور خالد تفضل.
Yeah, I am calling from Khartoum, you know that.
Yeah,
and,
we are happy to hear you.
In our region, we had a big debate about the use of either Dex or Eluva or Avastin or to use Lucentis. What is the best and for how long? Some people think that if you use it for more than 3 months, this will drain the patient, and the economic situation of the patients cannot allow them to maintain the treatment. Other people think that we have to treat more than 6 months. And we raise the question that some people, they develop geographical macular atrophy when you use it more than 6 months. What do you think about that?
Which type of medication you are asking? All, I mean, anti-VEGF or steroid?
You know, I'm speaking about the anti-VEGF, Lucentis and Avastin.
Okay. So is there any comment, Dr. Ramin, about Dr. Khalid, his questions? Did you get
obviously, what you are asking is the effect of anti-VEGF agents on geographic atrophy. Yeah, I would say that this is a little bit more important in AMD treatment, and you're absolutely right that there might be a risk, if you are continuously treating patients with anti-VEGF agents, that geographic atrophy might increase. But I would say that to worry about geographic atrophy in a wet AMD patient is not really what we should do, because we know if we don't treat the wet AMD, that for sure will lead to legal blindness very quickly in that patient. And I rather accept a slowly progressing geographic atrophy than not to treat the patients. I would never treat a patient because I'm afraid of inducing or making geographic atrophy appear more quickly. And I would say that in clinical setting, it's not really very worrying for me to see that.
How about in diabetic macular edema, Dr. Raman?
Yeah, in diabetic
there is no issue about this one, I think.
I would say that diabetic macular edema is obviously it's a completely different disease from AMD, and I would also say that in DME I really see a space for corticosteroids, because we all know that DME is an inflammatory disease, and we all know from our medical studies that a very good drug to treat inflammation is obviously a steroid. VEGF is obviously increased in patients with diabetic macular edema, but it's not the only factor. So whenever you are giving anti-VEGF agents, you are just treating the VEGF, and you are not treating all the other inflammatory responses that you see in that eye. And that's what I like about corticosteroids, that you have a much broader approach in such patients.
Dr.
Okay.
I have a
another
question.
On mind, which is very annoying us.
Yeah.
In the last period, we had a lot of young people who had CSR. Okay. And long-standing and not responding. Should I give them intravitreal steroid or anti-VEG, or should I wait for how long? And what is the prognosis for those young people, especially those who had bilateral CSR?
CSR chronic. You are talking about chronic CSR.
Chronic.
So this is another question. Let us have first Dr. Brasan comment, then we will go. Dr. Brasan, please.
So, Dr. Ramin, this excellent presentation and a good overview of the use of Eluvium in real-world studies. So, I have two questions. The first is, in this part of the world, when you use Eluvium, as the label suggests, we are supposed to use a steroid, just to make sure that the patient is not a steroid responder. So do you use any particular steroid? Because I know in the EU label, there's no mention about use of steroids to check steroid response. So that's the first question. The second question is, does Eluvium have an influence on the level of the diabetic retinopathy severity scale? Does it alter? Or in the long run, especially three years time, do you see any change happening? Or do you still see progression in the diabetic retinopathy?
Two very important questions. So first,
can we have Dr. Khalid answer Dr. Brasan? I want to answer Dr. Khalid his questions. Then we can go to your question from Dr. Raman.
Sure.
Please, Dr. Brasan, go ahead.
So, when you do you want me to comment on the CSR?
Sorry? Please. No. Can you comment on CSR?
So, if you have a patient with chronic CSR who's got bilateral fluid, the first thing you need to rule out is the patient having any steroid? Is the patient being on a steroid medication or any medication which is triggering this condition causing bilateral CSR? The second thing is, there are various ways you can consider treating it. You probably get a ICG done to check for whether the patient has any choroidal hypopermeability or any leak which is present. And if you don't see a leak, if you see a leak which is a focal leak, then go ahead and do a laser treatment. If that is not the case on your angiogram and the patient seems to have a pachychoroid, one option is to consider medication. So here in this part of the world, we've started using spironolactone and even melatonin, and we give about 3 milligrams of melatonin 3 times a day. And some of the patients respond really well. If you have options of doing micropulse, that's also a good option to treat your patients. And lastly, if nothing really works, then the option would be to consider doing either a half dose or a half fluence photodynamic therapy. Now, the entire prognosis of patients with chronic CSE depends on the main factor is how is the RPE functioning. The longer the fluid stays in the eye, the more damage it causes to the RPE, and that's going to compromise vision for the patient. So treatment ideally should be, yeah.
There is no rule for anti-VEGF whatsoever in these cases, right?
Yeah, so anti-VEGF is only done if the patient has an associated pachychoroid neovasculopathy.
Or there is CNV. Some cases they are getting also neovascularizations, choroidal neovascularizations. Some of them they are something like this. This is the only I think indication that we can use anti-VEGF.
Yes. Totally agree.
I think that OCTA can show that clearly whether they have it or not. So OCTA can exclude those groups of patients that they are chronic and they have this mixed choroidal CNV, and definitely here the rule of anti-VEGF. Otherwise, as Prashant said, the angio and selection of the any leak with the focal or micropulse. Personally, I'm using micropulse, and I have a good result with them.
Thank you, Dr. Safwan. Can you have now the answer for 2 questions from Dr. Prashant to Dr. Raman? Dr. Raman, go ahead, please.
Yeah, so the first question was, if we do a steroid test in our patients. I know that a steroid test, for example, in the United States is required. Yeah, in Europe, that is not the case. Yeah, we don't have to do a steroid test. And I must say that we most of the time also don't do that. And we don't do it simply due to the fact that if you react to one steroid, it doesn't necessarily mean that you will also react to the other steroid. Yeah. For example, if you are giving an Ozurdex and you see an IOP increase, it does not mean that you will also see an IOP increase with the Eluvium and vice versa. Yeah, so you can have a patient who does not show an IOP rise with Ozurdex, and then you go for the Eluvium and then you see a pressure spike. Yeah, and that's why, in our opinion, it does not really make a lot of sense to do that steroid test, and we basically don't do it. Yeah, but as you could see from the data, I would really say that IOP increase is not something that cannot be handled. It's very rarely required that we proceed to surgery in such patients. Obviously, it's important to advise patients that it could happen, but most of the patients who have a IOP rise can be treated very effectively with just topical medication. And once again, we are talking about patients who have not responded well to any other therapy. And I mean, if we can control the disease and they only require eye drops, I think it's still a very good agent in some patients, in such patients.
I think, Dr. Raman, regarding the intraocular pressure, the percentage of those they are not need any medication, about 69 or 70%, they are not having any change in the intraocular pressure.
Exactly.
So they need only, though they are having a little raise, it is about 19% or 25% of them, they are only a small number, and they can respond quite nicely to one even type of anti-glaucoma. The only very few percent, the numbers which is about 5%, or even now with real life study, as you show, it is even smaller than that. So they need, more anti-glaucoma. They can reach to 3 types of 3 drugs, and at the end maybe we can have a surgery, but I think it's very small number in comparison even to the real study, which was more they need surgery. It was 5%.
Exactly.
But in the real life, it is very less.
Yeah, exactly. And even if you need glaucoma surgery, it does not necessarily mean that you go blind. Yeah, a lot of glaucoma surgeries also go well. Yeah, so it does not mean if they undergo surgery that it's a very bad result for the patient. Yeah, regarding the second question, yeah, I think the second question was about the effect of corticosteroids on diabetic retinopathy, and I think that this is a very important issue. Yeah, in contrast to AMD, we all know that diabetes is not only affecting the macula, but it's affecting the entire retina. And we know very well from a lot of studies about anti-VEGF agents that anti-VEGF is not only doing very positive effects on the macula, but it's at the same time also preventing the retina to go from non-proliferative diabetic retinopathy to proliferative diabetic retinopathy. When we look at the same findings in the trials with the Eluvium, I can tell you that the results are very much comparable to the results that you see with anti-VEGF agents. However, in anti-VEGF agents, you have to give the drug every month. Yeah, the data that shows good results only shows good results if you give the drug every 4 months. And we all know that in real world, that is very difficult in diabetes patients for 3 years, yeah, to give them every month an injection. And that's, I think, the real advantage of the Eluvium is that you give it once and you have the effect over a 3-year follow-up.
How far is how do you find the effect of the Eluvium in the management of diabetic retinopathy?
The several studies are really looking at the severity, the ETDRS severity score. Yeah, so that is really what is normally just assessed in clinical studies. Yeah, in our daily routine, we also don't assess the patient for using the ETDRS severity score. But there are a lot of published literature, both in anti-VEGF treatment and also in Eluvium treatment, which have really looked at the ETDRS severity score in such patients. And when you look at the numbers, they are basically the same. Yeah.
Dr. Mohammed, can I have just
yes, Dr. Safwan, yes, go ahead.
One thing, Dr. Ramin, what was the percentage of myopic eyes among your the groups of the studies that you did? I think that 290 something. What was the percentage of myopic eye? This is a modification to Dr. Rao question.
Yeah, I have to tell you that I would have to look that up. Yeah, it's not in the slides. It's not included. Yeah, so I really cannot.
We can ask about this one later on, or we can check and get it back to Dr. Safwan. We are having who's there? Mariam, and also Dr. Abdul Ghani is there. Is there Abdul Ghani? Can we have Dr. Abdul Ghani if he is there? If not, we can have Dr. Mariam Al-Shehi. Dr. Abdul Ghani, if he is there, and he can give his questions live. Can you open for one who is ready? Dr. Nabil Ali or Dr. Mariam or Dr. Abdul Ghani? Anyone who is ready, please go ahead.
Assalamu alaikum.
Dr. Nabil, wa alaikum salam. Tfaddal, Dr. Nabil.
Thank you for this webinar. I have one question. From daily practice, we have a problem how to help patients with subfoveal exudate in macular edema to improve their vision. It's surgical or medical treatment or systemic. This question for all panelists. How to help patients with macular edema, diabetic macular edema, with subfoveal hard exudate.
With so what? Sorry, I couldn't hear you.
Subfoveal, submacular hard exudate.
You mean there is a hard exudate in the macula?
Yes, in the fovea, subfoveal. Not only the
hard exudate, and they are diabetic macular edema. How can help them in management? Okay, you are talking with us from where, Dr. Nabil?
From Yemen, Dr. Mohammed.
أهلا دكتور نبيل، مساء الخير، كيف حالك؟
حبيبي يعطيك العافية، كلام طيب.
ما عرفت والله، حبيب.
يعطيك العافية حبيبي والله.
Okay, Dr. Nabil is asking, there is some patient, they are having diabetic macular edema, and associated with that, there is a foveal hard exudate. How can we deal with these cases? And this is what I understand from Dr. Nabil's question. Dr. Ramin and Dr. all the panelists, this question for all, anyone have an idea, or he can tell us any experience about this one.
Yeah, I think one of the study that compared the it was because of Bivordix trial. It's comparing dexamethasone implant against Avastin, and they look at the extension and the position of hard exudate around the macula, and they found that as much more improvement of the resolution of the hard exudate in the dexamethasone group compared to anti-VEGF or Avastin at that study. And personally, I've seen that also, that steroid help a lot in the hard exudate. But the question, as Dr. Nabil mentioned, what's happened if this hard exudate become like a plaque and hard and deposit at the fovea? It's very challenging. And I know that some approach to remove it surgically, which I'm not a big fan of that technique, but I think that the best way is to avoid deposition of this. Once you find this hard exudate started to develop, I think you have to treat it early and put in your background that you might use steroids. If you are not a big fan of steroid, I think you should give attention to steroid on those patients to try it earlier. And I have tried that, and I found that it's very helpful. But the issue is to do it early, not wait until the hard exudate become thick and deposit under the fovea. Yes, that's my approach.
How long, Dr. Ahmed, you will use steroid? For how long? I mean,
no,
what you are going to give, for example, Eluvium for 3.5 years, and it will be fair enough, or you want to give?
You just you give the steroid regardless, which you follow the protocol for sure. If you are going to Eluvium, you have to wait a long time, and you have put an eye also on the efficacy of the drug in terms of resolution of the hard exudate. You have to look, and I think most of the patient does not at least does not increase the density and the number of exudate at that time. If you're using a dexamethasone implant, you should go for protocol. I think most of us agree that it does not last in the eye 6 months. I think most of us agree that maximum 3 to 4 months, and you have to repeat it accordingly.
How do you assess the improvement, or there is a response in dealing with this, Dr. Ahmed?
Yeah, you will find, if I showed this case before, you will find that the hard exudates, it will disappear. Really, it's really disappeared. The small
How long it will take? How long it will take to disappear?
It start to like 2-3 months, because in those patients I use dexamethasone implant, and I found the result after the first injection. After 3 months, start to resolve, and when I get another injection, it's almost disappeared all except the plaque. It was hard plaque, but it was parafoveal. So the patient was okay, but it takes time for sure. It takes time to.
Is there another opinion in the same as Dr. Prasan? Yes.
So besides what I totally agree with what Dr. Barki said, M. Barki. So steroids are the way to go. So once it becomes a plaque, it's actually quite difficult, because usually these patients will end up with a subfoveal involvement of the photoreceptors, and they generally tend to have poorer vision in the end. So one way to look at it is, about 10 years back or 15 years back, there was a paper published in American Journal, if I'm not mistaken, and they looked at the role of atorvastatin, to look at migration of the hard exudation from a parafoveal area into a subfoveal area. And they found that use of statins is a very good way to curtail the migration of these hard exudates. So if you're looking at patients who have extensive hard exudates in the parafoveal area, I think besides the use of steroids, we can also consider using statins in conjunction with the internist or the endocrinologist.
What else? What you said? Sorry, in addition to steroids, what you
Statin. So you need to talk to the internist and see if they can introduce statins. I'm not so sure about the other medication. They commonly use fenofibrate, which is Lipantil, which is again basically for triglycerides, anti-triglyceride medications. So that also can be considered in these patients.
Okay.
I totally agree with Dr. Barke. Steroids.
Okay, I need to hear from Dr. Ramel. If suppose, if the plaque is there, patient came to you, what can you do in this case? So is there a chance for surgery, or you cannot leave the patient like this if the patient came in this situation?
Yeah, you're completely right, and I just want to emphasize, yeah, and repeat, yeah, what Dr. Ahmed has actually said. Yeah, what we do in Europe, we quite strictly follow the Euretina guideline in these cases, and it's very important, yeah, when it comes to the use of steroids, not to use them too late. Yeah, the Euretina recommends to already switch to steroids when you notice after 3 to 6 injections that it's not working. And I think that is something that makes a lot of sense. Yeah, you can always start with an anti-VEGF agent, but if you after 6 injections do not really feel that it's working, then I think it's a good time point to go to steroids. The problem is that many patients, many doctors, yeah, use steroids, yeah, only when it's already too late. Yeah, and if it's too late for the patient, then you cannot really do anything for the patient anymore. And I can really only agree, yeah, to do that early enough. And there was another question. Yeah, maybe I can also address that publicly that I was just responding to in the chat. Some of you might be aware that uveitis, at least in Europe, has also been approved for the use of uveitic macular edema. And in fact, in the beginning of last year, yeah, we have published a paper in the Journal of Ophthalmic Inflammation, where we reported about our real world results where we used that drug in uveitic macular edema. And I can really tell you that the results indeed have been excellent, and we are routinely using that drug now in our patients with uveitic macular edema. What is different in uveitic macular edema, yeah, that we are obviously very frequently already using steroids in such patients, yeah, and we are not really afraid of using such a drug in these patients. And you all know these patients are oftentimes very young. They have a lot of activity going on in their eye, and whenever there is a drug which can really calming down the eye for a long time, it's something really that we want to see.
I mean, Dr. Raman, still we didn't get, actually, I don't understand if the other, if there is a central foveal break due to diabetic macular edema and there is no chance to give or to treat it with anti-VEGF or steroid, if there is a chance for a surgery. I know there is a lot of debate about this one, but if you have any experience or any suggestion about this one, and how I mean, the success rate of this surgery in this.
Yeah, I'm not a fan of surgery in such cases. I would say that it's basically very difficult to treat, and I would say that it's in most of the cases it would be too late.
Dr. Prasad, you have any comment?
No, me too. I'm not a fan of a subfoveal removal.
So the patient, you will try with him medication and wait and see. That's it. So Dr. Nabil, I think you hear all the suggestion question. Nice to hear Dr. Nabil and to listen to you. Now, if we have Dr. Abdel Ghani is there, if you want to talk, Dr. Abdel Ghani, Dr. Mariam. If no one is there, so we can just go ahead for the next presenter.
Yes.
Any response, Mr. John? Any response?
Nothing.
Okay, we are having Dr. Yasser. He's there. You want to talk or to ask questions? Okay, can you unmute him, please? Dr. Yasser, unmute, please, Dr. Yasser.
No response, doctor.
No response. Okay. So now it's our pleasure also to have Dr. Arif Abdinola. He is a consultant ophthalmologist, Zuleika Hospital, Sharjah, UAE. He is having FRCS ICO, and Dr. Arif, he will give a talk also about the medical retina, one case. So let's have Dr. Arif. Thank you, Dr. Arif.
Thank you, Dr. Amri, and thank you, the Alumni for Alumniva to invite me for this session. I'll be just sharing you a few cases. Yeah, I think it's visible. Yeah. So after listening to the talk by Dr. Ramin, I'll just present the few cases where I have used Eluvium, and my data for 1 year. There are a couple of cases are there. Yeah, so there's no financial disclosure. Eluvium, as you all know, is injected 0.19 milligrams, indicated for treatment of diabetic macular edema in patients who have already been treated. Like in UA, we always try a course of steroids and see whether steroid responders are there or not, and then try to inject, and so that there is no increase in the intraocular pressure. So the first case is a 65-year-old male patient, diabetic since 20 years, well controlled. The patient has taken almost 10 anti-VEGF injections and 1 Ozurdex, and he was fed up because he didn't want to come and every month or every few months and take the injection. He was looking for some options, and in between he got his cataract surgery done, and we had a good response with Ozurdex. So I wanted to know if there is any injection where it can be prolonged and we don't need any anti-VEGF in between. Because when we shifted from anti-VEGF to Ozurdex, he was happy because that injection stayed for almost 3 to 4 months. So then I explained to him about this Eluvium injection where the results can be there for long term, but in between you might need to add anti-VEGF. So all these things were explained to him before taking him for the injection. So this is the picture where I showed the pre-Eluvium, the central retinal thickness was almost 885, visual acuity was 660, the IOPs were normal. The first follow-up, after 1 month, you saw the CRT going down to 660. The vision also improved. IOP was still controlled. The second month follow-up, you can see the hard exudates were there, but the thickness gone down to 385. The vision improved to 618. 618, the IOP was 15. Then the third month, the CRT was maintained to around 395. And the vision was 618. The pressure was well in control. We didn't go for any anti-VEGF right now. We just wanted to wait and see the response. Then fourth month, the thickness was maintained. There was not much visual improvement, but the patient was happy. And even 6-month follow-up, it was quite stable. And in 7 months, you saw the thickness going down to 295. Vision improved to 612 part. The IP was under control. At the 8th month, I saw that the thickness has increased to around 500. The vision also went down. This is the time where anti-VEGF was injected because the patient also complained, and I didn't want to wait more as the thickness has increased. So anti-VEGF aflibercept was given. Immediately after the injection, a 10-month follow-up, you see the thickness going down to 310. And the last follow-up, which was done in June, the CRT was 280. The patient vision was 612. Patient was happy. And the regular follow-up will still be going on, and then let's see what is the results. But the best thing was the pressure was under control, and the patient needed just 1 injection in the whole 1 year of anti-VEGF. So compared to the previous injections of almost more than 10, he was quite happy with the response. And the second case, also a 65-year-old male patient, where the patient had taken almost 6 anti-VEGF. Same 1 Ozurdex injection was given. So normally I always try to check for the steroid responders and seeing the response with Ozurdex. I don't want to take the risk of the steroid responders. And I also, at the same time, I heard there was 1 case of Eluvium removal. So I don't want to take that chance. And plus the patients was pseudophakic. So the caution of secondary cataract was also less. So this was the pre-Eluvium thickness 767, vision was 6/60 before the procedure. 1 month, the thickness went down to 490. The pressure was under control. The second month follow-up shows the CRT of 480, vision improving to 6/24. Third month, it went down to 350. The vision improved to 618. The pressure was under control. So there was a gradual improvement at each visit. So patient was happy, and even I was happy. We don't need any extra injections. So 5th month the thickness was 300. Then even at the 9th month, you can see the thickness has gone down to 290. Vision was 612. And the final checkup, which was done last month, this month in June, it was central retinal thickness was 285, macula was stable, and vision was 612. So he didn't need any injections, no anti-VEGF in between, and patient was comfortable. So you see the thickness, the pre-Eluvium about 700 plus went down gradually. and to around 250 or so in 12 months, and it was stable. So how much it remains stable, whether I need any anti-VEGF later on, I'll see, and maybe in the next webinar I'll try to present it. The IOP was stable in both the cases. There's one more case where it was a young patient, 45-year-old male, 8 years, diabetic, well controlled. He had 4 anti-VEGFs and 2 Ozurdex in injection in the past, and the response was very good with Ozurdex, but he also wanted to have something which can stay for a long time. So here you see the pre-Eluvium CRT was 582, the vision was 660, IOP was 16. And the first month vision went down, vision improved, and CRT went down to 420. Then he came after 3 months, it was 350. Vision improved to 618, IOP was 15. The last follow-up, which was 6 month follow-up, that was in this month, the CRT was 270 and vision was 612. So till now is stable, and let's see later on if we need to give anything. So thus we see that once we give the Eluvium, the thickness gradually goes down, and there is improvement in the visual acuity. And all my 3 cases, the IOP was well controlled. And patients were happy, no need for frequent injections. Follow-up visits was reduced. But the main problem always remains is the cost. So, and plus I don't usually explain to them that the injection will remain there for long term, and you will not need any anti-VEGF, because obviously the number of anti-VEGFs will be less, but this is always explained to the patient that you might need to take the anti-VEGF, whether it is after 4 months, 6 months, 8 months, it depends. But definitely the number of injections will be much less. Thank you. That's my
thank you very much, Dr. Arif, for this presentation. Excellent presentation, and also you are giving a different type of response. I think Dr. Ahmed, he will have a comment because he's having also a lot of experience in giving Eluvium. If you can comment about
no, it's not big. Yeah, thank you, Dr. Arif. Very interesting cases, and it carries some important messages. I think in your first case, you need only 1 anti-VEGF for the whole 12 months. Yeah, and one Eluvium, and then for the 12 months period, it needs only another 1 top up.
Yeah.
So I think in terms of cost effectiveness, I think it's not costly if you compare it with the other treatment protocol. I think at the term after 2 years, you will end up with more expenses if you calculate it in terms of cost effect. And this is one of the arguments when we apply for approval. Because we still has non-formulary in our hospital, but we have discussed it. The second point, what I want to highlight, the when you start to top up in the first case, because as we had discussed with Ramin before, I believe that you should wait, don't rush for the top up. And I mean, my message here, if you give an Eluvium for a patient who didn't respond well to anti-VEGF, and for example, the thickness before Eluvium was 350, I will never give top up as long as the thickness is 350. The only thing that I will top up if the edema increase. That means that it's something happened, so I have to top up. But if it's still stable, because one of the reason of giving long-acting medication inside the eye is to maintain the avoid the SUSO or the recurrent edema, because on and off fluid, it will affect, and the final outcome will be poor. So the message here, don't rush to top up unless the edema increase. But as long as the edema is stable, give some more time, because we are treating patients with uncontrolled diabetes, hypertension, a lot of comorbidity. So it's not controlled patient. So you might need more extra effort for that.
Thank you.
So that's my 2 comments. Yeah.
Thank you, Dr.
Can I talk, Dr.
for the comments? Yes, Dr. Arif, please.
See, that's the reason I presented the first 2 cases. In the first case, the edema was around 700. It was stable around 350. I waited for a couple of months, and then it went to around 500. And I thought it's better to inject.
No, sorry, I agree with you. I'm
He
not saying
is
you are
not
rush.
comments.
In your case, you are doing this. That's what I'm doing. I don't
that's
rush
right.
because some people you didn't find the response from Eluvium after 2-3 months, but it's still edema the same. So they send them to give more, just helping to hoping to get more result. But what you have done is, I think,
in my first case, I was little get restless. Then I contacted the company and I told them. They told me just wait, because the first case, then the expectations was also there. Patients was not so happy. So I told, wait, let us see. Inshallah, the edema will reduce. But in all
I
my
think you have done a great, Dr. Arif. This is what everyone. But there is a question for all. All here speaker panelists. What is the minimum? What is how many months after the Eluvium that you can start top up? Is there, if we talk about months, what is the least number of months that you give injection top up, Dr. Rahman, for your patient? Because I have experience and I start top up in one cases after 6 months. And I feel, yes, if there is a big difference, there is a change. And we have to take care about the control of diabetes, hypertension, the other method should be there, because otherwise maybe it will be not only the response of the treatment, rather also the effect of systemic. So I need to hear from each of you, but in a very fast comment, please. We are having only 2 minutes. Dr. Raman and Dr. Prasan.
Your mic is muted.
Yeah, you can go ahead, Prasan, and then Raman.
We can hear.
Yes, Dr. Raman, if we are waiting for your comment. He is also muted. You are muted. Can you unmute yourself, Dr. Raman?
Yeah. So till Dr. Raman speaks, I think I totally agree with Dr. Ahmed. You generally need to wait for some time, allow the medication to work, to have its full effect, and then consider giving anti-VEGF. Though my experience with Eluvium is not much, but I totally agree with what Dr. Barki says. Okay,
Dr. Raman?
Yeah, I also agree with what you said. Yeah, you should definitely wait several months. Yeah, until you top up. Yeah, it's not necessary to do that too quickly.
I think there is 2 things here we have to differentiate. There is a response for the management of Eluvium, and when you can say there is no response, is something different. And there is a response, then recurrent, and then you want to top up and give and improve the vision. It's 2 different issues here. So in case of waiting, we have to wait. If there is no improvement, you have to wait a little bit more, 2 to 3 months, then you can get a response. But if there is a response, and then after that, there is a recurrence, and there is an increase in the thickness of retina and central retinal thickness, something more than usual, 200, 150 micron, then I think this is the time for top up. Do you agree with me in these things or not? Dr. Ahmed?
Yeah, I think, yes, I agree. The question here, Dr., or the issue here, Dr. Muhammad, I think, because most of us, I don't know, I think the question will be valid if you are using Eluvium as a first line. But usually, at least in my practice, I don't use it as a first line. I usually start with anti-VEGF, and then I have steroid. And if there is it's come after as a second line or third line as a steroid. So I already tried my best with anti-VEGF. So I'm not expecting to get more response. So once the medication I'm using at least stabilize the vision and stabilize the edema, I'm happy with that. If it improves it more, it's well and good, but it's not. But usually we do use it as a later stage, not an early stage. That's the issue here. But I think with Dr. Raman, I think they are using it. You can use it as first line in Europe, right? You don't have to try anti-VEGF. I think in that situation, if you use it the first line, that we can ask how long you can wait until we get a result or before top up. This is different situation. That I understand it is this way.
Yeah, in Europe, from the label, you cannot use it first line. Yeah, but the Euretina guideline actually, but the Euretina guideline says that you can also use a steroid in patients who is not willing to come for monthly injection. So you could basically argument with the Euretina guideline also first line treatment. If the patient already tells you at the first visit, I cannot come every month, then you could think about that. But it's not the official label of Eluvium. Yeah, but I think you could go with that.
Any comment? Yeah, last comment, Dr. Prasad.
So my question is to Dr. Ramin. If a patient is having cataract or has a clear lens, would you still consider giving Eluvium? And if you give Eluvium, what are the chances that the patient is going to develop cataract in future?
Yeah, regarding cataract, yeah, I would say that if you are treating a patient with Eluvium, yeah, during the 3-year follow-up, you will most likely see cataract that needs to be operated. Yeah, so basically, for a very young patient, yeah, who is still can accommodate with his own lens, yeah, I would be a little bit hesitant. Although, if I have a patient, also a young patient who is not responding well to any other treatment options, I would also accept cataract. Yeah, but obviously, I normally prefer a patient who is presbyopic already, and if cataract is occurring where it's not such a big problem, and if the patient even suffers from cataract, it's always also better. Yeah, obviously, I don't want to do harm for the patient, and but that is some effect. Yeah, it's that you have to take into consideration whenever you are using steroids, that eventually you will get cataract. But in most of the cases, we can address that quite easily with surgery.
Thank you.
Thank you very much. I think I will ask this question for all panelists actually. This question came from Dr. Aid Al-Khulaibi. Is there any rule to inject anti-VEGF for a patient with neovascular glaucoma with full AC angle neovascularization and raised IOP and plan for trabeculectomy? Anyone want to answer, Dr. Safwan or Dr.
And the issues is that the main problem in the neovascular glaucoma that we are facing is the high intraocular pressure and uncontrolled. And they are coming to us when the intraocular pressure reaching, for example, 50 or 60, and with full the rebuses reaching the angle and covering, and the angle or trabecular meshwork angle is covered with the fibrovascular membrane. So one of the rule here for the anti-VEGF is just to prevent bleeding when we are decide to do Ahmed valve, for example. So yes, there is a rule, but it's not an immediate, because we have a pressure of more than 40 or 45, which is uncontrolled, means that the patient taking full medication and we need to inject more, so we will increase. So there is a risk of CRVO or central retinal vein occlusion or central retinal artery occlusion. So I'm saying yes, but with the certain conditions when we need to prevent or we are planning to do Ahmed valve.
Yeah, I think Doctor, he already mentioned that he is going to take the patient for a surgery.
Yes.
And that means he can just give it 2 days or 3 days before that. And
yeah.
Also, if they can give it a mannitol, if he can give the patient, with any additional things that can decrease the intraocular pressure. Well, I know it's very difficult in neovascular glaucoma.
In neovascular glaucoma, when we are talking about neovascular glaucoma and mannitol and Diamox, and these medications will not work in case of neovascular glaucoma and pressure is 60 with all full medication. So I'm saying yes, if the patient is intraoperatively, and intraoperatively means that on the table of the operation, and the surgeon doing Ahmed valve, the answer yes, he can use it, because that will prevent the AC hyphaema post-op.
Thank you, Dr.
I think just to make it more simple, it's just the same idea, the same concept when you are using it in BDR and you want to inject pre-vitrectomy to regress the vessels so you don't have a lot of bleeding intraoperatively. And Dr. Safwan said yes. I think for sure I'm not glaucoma specialist, but I know that this kind of cases, it's very hard, because I think the question he mentioned, TRAB. I think TRAB in those cases, it will be a higher failure. So I think the best chances do pre-op. I know my glaucoma colleagues, he inject intracameral, by the way, the Avastin or anti-VEGF, and then go for Ahmed valve to prevent the
anyway, it's an intracameral
angle bleeding. Yeah.
Anyway, it's this is the rule.
Yeah.
Thank you very much. Now we will start the second session. In this one, I would like here to introduce my dear friend, Dr. Imad Musallam. He is a consultant ophthalmologist, vitreoretinal and anterior segment surgeon, associate professor in Royal College of Medical and Health Science, University Iraq UAE. And today is I have an honor and glad to introduce a new technique that done by Dr. Imad in dealing with cataract surgery, a phaco-shop technique new that he will show us now. Dr. Imad, the mic is you. Please, you can start sharing your screen. Thank you.
Now it's good?
Yes, we can see your...
Yeah. Good evening, everyone. Thank you for having me. I would like to share with you our unique technique of nucleus chopping that I and my colleague, Dr. Mikhail, have been using for 15 years. We call this technique posterior anterior chopping, or in short, PAC technique. I believe this technique is very efficient and safe way to avoid complications during cataract surgery. Most present phaco-chop techniques performed anterior-posterior chopping using sharp vertical choppers. In contrast, PAC is posterior-anterior chopping using a flat, curved, and blunt Koch spatula. Difference from regular techniques is only the direction of chopping. All other phaco parameters and the rest of surgical steps remain the same. This is the spatula. What we are using as a chopper is it consists of two surfaces, flat surface and lateral edge. This spatula have curved surface that goes along with the shape of nucleus and posterior capsule. A spatula position under the nucleus. In these pictures, I show you with soft nucleus, flat surface facing the nucleus, the tip at the center of the nucleus. But in moderate and hard cataract, lateral edge facing the nucleus, tip at the opposite quarter of nucleus. Here we are prepared for you the animation video. I want to thank Dr. Mikhail. He spent last 2 weeks to prepare this video to make it easier to understand and exactly what we are, exactly to show all our steps. As you see in this video, we starting by inserting the phaco tip in the center of nucleus, and then we lift and tilt it slightly. This allowed us to slide the spatula under the nucleus. Next step, the spatula going vertically, posteriorly, anteriorly to make first chop. And another pieces of nucleus, we are the same manner as first chip. Now we are going for how it's coming with the live surgery, real, I mean, cases. I will start with soft cataract. As you see, standard cortex removal and mechanical delineation. I would stop just for a few seconds about mechanical delineation. It's moving the epinucleus of the with the spatula to create layer of protection of the posterior capsule. This is very important to save, if you can, all the time, the epinucleus to work as protection of the posterior capsule. And as you see, first chop is done. After that, we are aspirating the cortex, the material of nucleus. This is second half of the nucleus. And as you see how easy we are aspirate, But in this case, I want exactly how to show you how we are performing 3 layers of protection. First, we are keeping the epinucleus and cortex. After that, the spatula working all the time between the phacotip and the posterior capsule as protection for posterior capsule. Second case, this is harder cataract. And as you see how we are performing first chop. After that, we are chopping and aspirating the piece, small pieces. Here, as you see, second half, we are pulling to the center, avoiding any pressure to the sinules. And we are here working in the middle of the, we have small pupil, and as we are pulling the nucleus in the center, the size of pupil, it's not that question for us. Another case, the same techniques, what we are using. First chop, we are using mechanical force to make our first chop. And after that, with spatula, we are dividing to small pieces to make it easier and easier for aspiration. And as you see, our spatula all the time working between the phacotip and the posterior capsule. Slightly, we are making a rotation, small rotation of the another half of the nucleus. And again, we are crushing the hard material to small pieces to make it easier and easier for aspiration. And as you see, we here saving the posterior, the epinucleus and cortex. As you see, we have bad reflex here. And as you see how we are removing epinucleus and the spatula all the time between the phacotip and posterior capsule as protection. This is not sharp spatula, and as you see, we are removing without any damage to the capsule. Here, as you see, implantation under irrigation. It's coming without any problem. Just in some cases, with glaucoma especially, we don't need to use viscoelastic to remove it. And as you see, very hard nucleus. We don't make groove to divide the nucleus, but we use our spatula with mechanical force to chop the nucleus into half. In this way, we are saving the ultrasound and minimizing the damage of endothelium. As you see, first chop is done. Now we are dealing with first half. And as you see, it's coming easy to using that spatula, crushing the hard material to make it smaller and easier for aspiration. As you see how we are chopping the all material, with hard material, and it's minimizing that way using ultrasound, using mechanical force all the time to minimize the using ultrasound. Little rotation, and we are going for second half. Again, the same way, the same steps we are using, crushing the posterior, the nucleus from posterior to anterior. And as you see, we have lost 2 pieces, and we are dealing with each piece separately. Again, we are crushing using the spatula. We are using with crushing flat surface. and to make the hard pieces smaller and easy to emulsificate. As you see, last two pieces, it's coming easier and easier for emulsification using our capsule. Again, as you see, we save posterior epinucleus and cortex as protection. And now with our spatula, we are working as to protect posterior capsule. As you see, epinucleus removal and the spatula working between the phaco-tip and capsule. This is hard cataract also without epinucleus and cortex, and we don't have any protection for posterior capsule. What here we doing? We are trying just to avoid any complication using our spatula to place it all the time between the capsula to make any protection for it, sorry. And as you see how his first chop is using that spatula, crushing, small pieces aspirating, again chopping from posterior to anterior, all hard or sharp edges is coming direct to the tip, to the phaco-tip, and immediately emulsificating. As you see, the capsule, posterior capsule, is without any protection now, and we need to work more to be more carefully while we are aspirating the hard material. Last piece, dividing again in the small pieces, and we're trying to aspirate it without any damage with the posterior capsule. As you see how it's hard material, and all the time now we are trying to keep spatula between the phaco-tip and the posterior capsule to avoid any complications. As I said, 3-layer of protection. Now in this case, our spatula working as third layer of protection posterior capsule. As you see, small last two pieces, we should to be carefully and to keep all the time the spatula between the phaco-tip and the posterior capsule. That's it. Here, implantation, and I want to show you this moment how again we are using this spatula for implantation. Last case, what I have, this is hard cataract. We are using with the subluxated lens. We are using retractors to fix it anterior capsular axis. And here we should to be little patient, and we are working as like slow motion, because we don't need for any fluctuation from the posterior capsule. And this is, you are working with low vacuum to aspirating the hard material without any damage to the posterior capsule. As you see, we are trying to work slowly, step by step. We need to take our time in this case because we have weak zonules. We don't need to make any pressure with the zonules. This is first half we finished. Second half, we are pulling it in the center, as you will see now, to minimize any pressure to the zonules. You see, we are pulling a little bit, and we are setting our spatula, and we are dividing the second half slowly to avoid any complications or to don't rupture the capsule. As you see, last two pieces, slowly, we are using our spatula all the time. We are inserting it between the phaco-tip, and posterior capsule. Next slide. This is summary of PAC technique. In this slide, you can see all our techniques, how we are dealing with that, and we talked about that during our surgery. Advantage of technique, we have a lot of advantage of this technique, but we are choose some of them. Most important things, this is suitable for all types of cataract, including subfixated, trauma, and pseudoexfoliation. It's achieved a more complete first chop, because using this technique, we are from the first step using this spatula to divide the nucleus to two halves. Spatula provide additional protection layer for posterior capsule, applies less pressure on the sinews. As you saw, we are moving, you are pulling the hard material to the center and minimizing rotation if in case we have weak sinews. Stable even in small pupil cases. Sometimes we are dealing with small, unfortunately, we are dealing sometimes with small pupil cases, but we we are working in the center of the pupillary zone. This is enough for us to 4 or 5 or 6 millimeters. It's enough to perform this technique. Suitable in high myopia and post-vitrectomy eyes. As you know, last time we have a lot of the patient with vitrectomy, and as we are pulling and holding this the nucleus in the middle of in the level of the iris, we can perform our technique without any problem. Thank you all for your kind attention. Hope this talk will be benefit for you and for your patient. Dr. Mohammed, I want to take 5 minutes, please, more. I want to share another case. Yesterday, we operate, you know, last 3 months, we don't have any surgery, only 4 emergency cases.
Can we have Dr. Imad first a little bit discussion, then we can go to the last case, if you don't mind?
Yeah, this case, it will be maybe minimize some questions. And
okay.
Maybe if you want, we can.
Okay, can you go ahead, Dr. Imad, in a fast, please? Yes.
Yeah. This case, you see this case? Yesterday with the lens-induced glaucoma, we admit the patient.
We are not saying.
Can you share the screen, Dr. Imad? You are still in the not sharing the screen. You are sharing the screen.
Cancel the presentation that you are present and go to the second case.
Yes,
because you are still on the same presentation.
It is in the same presentation, Dr. Imad?
No, it's indifferent.
Okay, so you have to stop sharing this one, go and open the another one and share.
Sharing?
Yeah.
Start sharing. Just a minute, please. You see the icon?
No, still not open.
Okay.
So you have to open first this one. Then, meanwhile, Dr. Imad, if we can have questions, meanwhile you are preparing for that. Dr. Ala, if you have any comments, actually I have been with Dr. Imad on his technique, and I saw all the his cases.
Now we can see the screen, Dr. Ahmad.
Yeah, we can see, but still the old one, but still the
okay. Just go ahead. Okay. Yeah, I think better. Yeah,
you can now go ahead.
Yeah, you can just see the screen.
Yes.
Yeah.
This patient with the 55 cataract, white cataract, and as you see, we have very high pressure in the capsule. A lot of these cases, when we have high pressure in the bag, when we are starting to make our capsular excess, sometimes we have Argentina flag. How to avoid this? We are using this this method many times, sometimes helping, sometimes not. We are using this spatula, making the pressure, we are pressing in the anterior capsule, making the pressure in the anterior chamber bigger than inside the capsule, and we are puncturing using the MVR small, as it's coming now. As you see, small hole we are creating in the anterior capsule, giving chance to minimize the pressure inside the bag. And after that, we are doing our normal techniques for this case. In this case, yesterday we are prepared for you one experiment. In the end of the surgery, I will show you how it's coming. This is everything standard. Here we are not using the, we are starting with the phaco-tip, I mean phaco-emulsification, without performing hydrodissection or hydrodelineation. And as you see, I'm tilting, I'm catch the nucleus, yeah, and slightly we are, as you see, we are chopping the same steps what we are using in the previous surgeries. As you see, slowly we are aspirating the nucleus. First half it's finished. But this is standard surgery or previous, but in the end, I will show you the experiment what we did. It's the same technique what we are using before. Here, as you see, we insert it's after finishing our irrigation aspiration, I insert the spatula in the posterior capsule, and I'm used phaco-emulsification tip to make a vacuum, and we increase the vacuum. Just I want to show by this experiment how the spatula, it's very safe to use it, and how, and you see how I'm increasing till 280, 300, and 350, and it's very safe spatula to use it. And when we are holding, when we are pushing the posterior capsule down, it's not, and we don't have any fluctuation, and we don't have any damage for the posterior capsule. Thank you for attention. I hope this talk will be benefit for you.
Thank you, Dr. Imad. It was an excellent. I have been with Dr. Imad in almost of his cases. I mean, shared it with me, and we discussed so many things. There is 2 points Dr. Imad maybe he forgot to mention. Dr. Imad, he is trying to catch the nucleus from the center by holding it in a very high vacuum. Then he's going back behind the nucleus itself without doing hydrodissection. He is not doing any hydrodissection, and just do a mechanical hydrodissection by the spatula itself, and go behind the nucleus and then start chopping. Whenever he is using this spatula, there is an edge which is sharp. He is using to go through the nucleus from back to anterior, or posterior to anterior, and the lens and posterior capsule and all the epinucleus, it will be protecting from having any damage or to touch the posterior capsule. I asked Dr. Imad also another question. If we are having a very hard nucleus that is it is all nucleus, there is no epinucleus, how we can manage and deal with this? Dr. Imad, if you can answer this question.
Yeah, I show you in the video when we have large cataract without any epinucleus and cortex, it's look like more look like 12 millimeters nucleus. But again, as you mentioned, and as you saw in our video, we are holding the nucleus with high vacuum. And after that, we are inserting our spatula slowly between the nucleus and the capsule, and we are performing first chop. And again, we are dealing with like normal, but in this case, we should know we don't have any covering for posterior capsule. We don't have 2 layers because when you saw our video, we have 3 layers. This is nucleus, this is epinucleus, and cortex and spatula working as protection. In your case, we have only spatula, and we need to use it very well, protecting the capsule. And we are all the time trying to keep the flat surface facing to the posterior capsule to avoid any fluctuation. When even we have fluctuation, the posterior capsule hitting the flat surface. And as you see in the last video, in the last case, in our experiment, how we, with high vacuum 350, we are just using spatula to
stabilize,
push the capsule back, and we don't have any damage if even we are using 350. Why we are all the time, you are working fast, and the vacuum, it's very important for us to high vacuum, very important. But the high vacuum we are using because we as using this curved spatula. And as you saw, all our cases, it's very easy to deal with, even starting from soft cataract and finishing with very hard cataract without any protection from the epinucleus and cortex.
Thank you, Dr. Imad. I need to have a comment from Dr. Ala and Dr. Safwan and all the panelists about this one. First of all, Dr. Ala, what do you think about this technique that is using Dr. Imad?
Like great, because all these techniques are done for, they have an aim to divide this nucleus. And he reached his aim by this way. My concern that few points to discuss. I believe that it needs a large pupil. I believe it needs a large rhexis. And what's about the most critical step, the introduction of this spatula to behind the nucleus. Why you don't مثلا put viscoelastic in this aspect? It will help you and it will protect the posterior capsule. We are doing hydrodelineation with BSS. Why not after hydrodelineation, or even some of my friends actually are doing visco dissection, putting visco dissection in order to have a visco layer between the posterior capsule and the nucleus. I believe this will help and a safety measure for you, Ahmed. Yeah. But actually, it's a very nice technique. I am impressed, really.
Thank you so much for the question. We used before, when we are starting with this technique, exactly, we are used viscoelastic and BSS, but with experience and with the high vacuum, it's allowed us to pull the nucleus little bit and tilt it to create space without any pushing viscoelastic to insert our spatula safety. But again, this spatula, it's very safe. We can insert it without, but if we are start with the viscoelastic, if anybody want to start, it's more safe to use viscoelastic, but with the time, the experience coming step by step, and you can very safe to work with it, especially with when we have soft cataract, when you are using, we can't use high vacuum, that we can use to protect the capsule, we can use viscoelastic. But with hard cataract and moderate cataract, we have hard cataract, we have nucleus, and we can use vacuum till maximum 600. With 600, I believe we can hold the nucleus, and we can tilt it, we can move it right and left. And what we are doing, complete to this question, and we are using manual delineation. What does mean? We are moving all the epinucleus from the nucleus, and we are trying to make it smaller even. Because if we have small pupil or small capsular rexus, sometimes happen, to be easy to deal with the small nucleus. And the question here, if you are trying to make manual delineation, what I mean, to move as you can from the epinucleus, and it's as you can, how much you are moving from the epinucleus, it will be more protection for our posterior capsule. And yes, we can use the viscoelastic, but with the time you will feel you don't need for that, because with small and slowly experience, I think it will be you will understand what you will do. And
thank you, Dr. Ahmad.
Thank you, doctor, for your question.
Excellent presentation and excellent way. And I was discussing this issue, so 100% Dr. Muhammad and you let me. I think that there is a sound coming from one of the speakers.
Yeah.
So we need to.
Our speaker who's having a children playing now, no problem. They can play later on another room.
Children around him, so you need to eliminate. The discussion, me and Dr. Muhammad, we are discussing a lot of issues in this life. One of it's this maneuver. So I'm very happy for Dr. Imad to have it, and the way that he presented in an excellent way, and the use of this spatula also in this way. But me and Dr. Ala, we are on a one wavelength of light, and we have the same chemical. So Dr. Ala always with me, sharing a lot of information in our head. So large pupil, yes. Large capsular rexus, yes. Now, who was started in supporting the nucleus from the back? Akahoshi was starting that technique using the end ball chopper. Now, when you're looking to the title, the title showing that chopping from the back, it's right. It's a chopping in a mechanical way. You have an excellent spatula, and that spatula having a little bit sharpness. And I agree with Dr. Ala, he's my master, saying that you need to protect the posterior capsule. Yes, with the time you will have easy to chop, to pull the nucleus and then chop it. That's right. But when you will use a ball end chop with angulation at the end, you will see that you will not be in need for a large capsular rexus, and you will not be in need for a large pupil. And easily you will go through and pass your chopper, ball end chopper, in between the anterior capsule remnant and the nucleus, and pull the nucleus. And with the mechanical support from the chop, you can divide, and you can use a even lower power than what you are using. Now, the issue is that I'm a little advice from your brother is that you need to calculate the power that you are using in this technique with the other technique, with the usual chopper, to show the difference. And I'm sure, as you said, that the power will be less in this technique. And you need to try the angulated end ball chopper and see if your hand will be better with the using of those two chop, and which one is the better. For me, in my hand, the ball end is better to do a mechanical chop, which means that supporting the nucleus from the back and chop from the using the chop as a second tool to chop the nucleus. Now, using hydrodissection with viscoelastic or without is one of the issues to protect the capsule, even if we are very expert. And thank you for
thank you, Dr. Safan.
Thank you, Dr.
You want
Safwan,
to-
for your comment.
If
No,
you
I'm
allow
agree
me,
with
Dr.
Dr.
Imad,
Yes.
yes, if you allow me, Dr. Imad, I think Dr. Safwan, I have discussed so many things with Dr. Imad about this one. The spatula is have a back surface, which is a flat. Even one side is sharp whenever you are rotated, one is sharp, the other one is bold. So there is no problem even when you are rotating to have a problem to do I mean effect or tears in the posterior capsule. And you are already having also epinuclear that another protection. He is not doing hydrodissection, he is doing hydrodelineation. His aim only to move the all epinucleus and all cortical matters back and only tackling the nucleus. So the nucleus, surely it will be smaller and it will be free when he is using a very high vacuum.
No, I'm not worried, Dr. Muhammad. I'm not worried about the posterior capsule. I'm worried about the entrance, as Dr. Ala said. You need a large capsulorhexis to enter.
No, there is no need. Even this one, it's not a need. I mean, by experience, it will be no need, because in the start, he is going to tilt the nucleus and bring it out. It will be like as if in the rim of the capsule of the rhexis. I mean, about the rim of the rhexis. Then he will go from that behind the nucleus. This
You're
is
right,
how.
Dr. Muhammad,
This is what how I understand from
exactly
Dr.
what we are using with high vacuum. We have a chance to tilt the nucleus, and we have a chance to push it little down just to see the equator of the nucleus, and we are slightly inserting our spatula between the epinucleus and the nucleus. Yeah, exactly, Dr. Muhammad.
Even
so Arif, he asked you one question, Imad. Arif, he asked you whether do you have any rupture of the posterior capsule in the initial cases that you did?
Yes, of course. We have sometimes happening with everybody.
Yeah.
And sometimes we are losing our attention. Sometimes we are working very fast because with the vacuum size 600, it's very dangerous. If you will lose some attention, sometime without mode, you are working and you will get 5 communications the same day.
Imad, that rupture was because of the spatula or because of the vacuum?
Sometime when we are using high vacuum, we are losing the balance between the aspiration and irrigation, and in sometime our spatula and it's busy with other things, and we are lose the protection of the posterior capsule, and this moment can be any damage for the posterior capsule. Yes.
No, Dr. Imad, I think the question is,
yes,
Dr. Imad, if you allow me, the question was, is there a rupture because of the spatula itself, not because of the phaco-tip?
No, if you are using it as the
question is, happened with you? Did this happen with you because of what?
Especially with the spatula, no. Just with the high vacuum, when you are working very speed, when we are having very fast aspiration, the irrigation at that moment, and we have little collapse, and the spatula just sometimes we are touched, or sometimes we have rupture when we are moving rotation, when we are rotated the nucleus. Sometimes some hard pieces, it's coming between the nucleus and posterior capsule during our rotation. In that time, we're making little pressure in the posterior capsule, and that time we have ruptured the capsule from the small pieces. Why I want to mention about we should to remove every free fragment, especially if it's from the nucleus, and if it's hard material, because sometimes we are rotating very fast, and that time that piece is coming between the nucleus and the capsule, and in that time we can rupture the capsule. But especially because if we are using very vertical our spatula, exactly you will definitely will rupture the capsule. But The question here with our spatula, this is curved, and that shape is the same as posterior capsule and the posterior, the posterior, I mean the nucleus. When we are using it, we see the sharp, even it's not sharp tip, but even that the tip, it's facing to the anterior part of the anterior. Sorry, I mean it's not that sharp to rupture the posterior capsule.
Okay. Yes.
Thank you, Dr. Ahmed.
Just can I have a comment, Dr. Mohammed, please? Because
yes, please,
it's an
yeah.
excellent technique from Dr. Ahmed, and thank you for sharing this with us. And I believe one of the most advantages of this technique, at least as I understand, it's for hard cataract. But what's interesting for me that it's because, as you mentioned, as you show us, the side of the spatula is not sharp. Despite that, you managed to show a very hard cataract. It was very interesting for me because usually in my thoughts, the harder the cataract, the sharper the chopper you want to use to cut it easily. But in your technique, actually, it shows we can try this little slant on the edge, and you still can do that. I think there is some tips or tricks because sometimes if you push against the phaco probe, sometimes the nucleus flip because it's very hard, it cannot cut. But are there any tips for that to do it safely in hard cataract? And one more question, because of the now the maneuver you are doing now with your left hand or your right hand, I mean the hand was holding the spatula or chopper, different than from the usual procedure you are doing with the normal phaco. You are doing to go a special space or place. So do you recommend or any tips where to put to insert your second incision, the position or the angle between the both instrument, I mean the phaco tip and the spatula? Do you have any tips for that to make our job easy?
Thank you for good question, Dr. Ahmed. About the spatula, how we are making first chop using the lateral edge.
Yeah.
In this cases, this is first hard cataract, and we need to insert our phaco tip as maximum as we can.
Okay.
And we fixed it and in that time when we are working with the spatula, we keeping 600 vacuum to fix it, the nucleus. And after that, with that edge, it's semi-sharp, it's going slowly. And you see we are using our, we are using mechanical force. And the question here with the mechanical force, you can use it as you want maximum, because the way it's going from the posterior to anterior. And which power you are going to use depends at the nucleus. But we need some time. If you saw when we are making first chop, sometime our hands from the power chop, it's shaking a little bit, but we should to keep our hands fixed.
Yeah.
And we are using when to perform, especially with the hard cataract. With the moderate and soft cataract, it's coming easier. We are using all the time flat side just to crushing, because it's soft material. It's not taking that. We don't need for that manual force to perform to deal with the nucleus. But with the hard cataract, yeah, exactly. We need more force, and we need, again, I'm telling we need to insert our phaco tip maximum down, because nothing to worry. It's like stone. It's one question. Another question, we are holding all the time 600 during our when we are dealing with the hard cataract, just to fix it,
okay,
the nucleus. About second question, as you see, I think it's easier if you are put our hands opposite each other. It's mean if we are making main incision.
He was the general.
Can you mute Dr. Arif, please?
Dr. Arif.
Excuse me.
Sorry.
Okay.
Yeah.
Go ahead, Dr. Ahmed. Yes.
If we are making our incision, main incision 2 o'clock, for example, we need to try to side incision to do it in 10 o'clock. It's look like opposite. If you are comfortable to do it 3 o'clock or 2 o'clock, but this position, I think it's good position if you have a very big nose. For example, some cases very deep, and that 2 position 10 o'clock and 2 o'clock all the time we are using, and we are switching main incision and side incision between each other, depend at the eye. But this our practice last 10 years. We are working exactly in that. Even when we are close your eyes and you are insert your irrigation aspiration without any searching, because you know exactly you don't need. Sometime if you are doing 9 o'clock, sometime if you are doing 10 o'clock, 11 o'clock, and sometime you need to search the incision. But if you are fixed your mind in 2 incisions and do 2 fixed position, it make your work more easier.
Yeah, thank you. It's very good, and also another advantage of your technique, which I like the most, and especially in hard cataract, it's you really, with this technique, you do much less stress on the denules, which is common to have a weak denules, hard cataract. So in your technique, when you do posterior anterior chopping, you're away from side pulling on the denules. So this is very good technique. Thank you so much.
Thank you, Dr. Imad, for this informative. Maybe we can have another discussion. After we are having Dr. Ala presentation, because already we are behind the times. If you allow me, I want to introduce my dear brothers and big brothers. Dr. Ala Al-Zawawi is a professor of ophthalmology, Faculty of Medicine at Alexandria University, Egypt. He is a well-known figure in cataract and refractive surgery. Dr. Ala will share with us some cases, and maybe after that we can have another discussion about Dr. Imad, our retina questions. We are having some questions and some people they are raising. Dr. Lama, if they allow me, after Dr. Ala we can have all of them. Dr. Ala, the mic with you. Thank you. Dr. Ala, we cannot hear Dr. Ala if you are mute.
Dr. Ala, you need to unmute, Dr. Ala.
Dr. Ala, if you are unmute.
Yeah. No.
Yes. Are you hearing me now?
Yes.
Yeah, we can hear you now. Yes.
Okay, I will present some cases actually, and I would like to have your opinion actually vividly, and don't hesitate to just to share with me your experience in such cases. My first case is a female, 63 years old, having a bilateral acute angle closure glaucoma following pupillary dilatation in some place. And this will pose a question actually of pupillary dilatation, and we have to look for the anterior chamber before doing such procedure. And she was on treatment. She was taking Sidamax, 2 tablets per day, Cosopt and Alphagan. The best corrected visual acuity was with a minimal astigmatism, 0.1 in the right eye and 0.05 in the left eye. Bilateral, very shallow anterior chamber, half dilated fixed pupils, tension in the right eye 17, in the left eye 47, in spite of this treatment. There was bilateral nuclear cataract 2+, and the fundus more or less I was able to see healthy discs. This is the anterior, this is the right eye, and we can see how how shallow the anterior chamber is. Biometry, we can have a look over. I am always fond of looking to the biometry. The axial length is 22.7 and the anterior chamber depth was 2.1, which is not very bad, but also not very good. The lens to be implanted was about 25, 26 of the thickness type, because I am using usually this brand. What's about the management? What do you think about the management? Shall any one of you go for trabeculectomy, for example, for peripheral YAG, peripheral iridotomy, or anything like that?
Dr. Safwan or panelist, if anyone has any comment?
Dr. Ala, first of all, when you have a patient with with the high intraocular pressure related to the close angle glaucoma. Now we are, as you said, that first of all to prevent from the dilating those patients. So I'm usually assessing. I think that Dr. Muhammad, we need to stop that sound because it's affecting our talk.
Yeah, Doctor, I think this is only near all panelists. One of the panelists, if you have someone beside, it can be close or mute himself. That's the only way.
So before dilating any patient's hyperopic, we need to look at the angulation by Scheimflug or OCT to see the angle, and then I'm doing PI before dilating to prevent close angle glaucoma on dilatation, or close angle glaucoma when we are shifting the patient to cataract surgery. Now, if you have a close angle glaucoma, we will try to do PI as much as possible, but believe me, with the use of mannitol and the use of pilocarpine, trying to reduce the pupil size, then do the PI. If you succeed, then that's a good chance to solve the problem. If not, and you didn't have any chance to do the PI because of the corneal edema and because you tried all the measures, mannitol and Diamox and all the measures to control the intraocular pressure, and you failed, then you will have a chance to go through. And that's what I had at in one case. I did everything, and with the mannitol, I could reduce the 50 millimeter mercury to around 30 or 35. And then I went and through a pars plana. That pars plana is only 2 millimeter because those are a hyperopic, so they have a very narrow pars plana. And I went through and I reduced the intraocular pressure, and then I did my phaco and removed the cataract, and then I finished. So here is one of definitely not a usual case.
Thank you, Dr.
Safwan. Is there any other opinion? Is there any other opinion from the panelists here?
No. My question just why we should do phaco in this case. Why don't we treat it as? Sorry, I'm sure I'm not a phaco. I'm not anterior segment, but because it happened before with us, the similar scenario, and our glaucoma consultant, he decided to do. He deal it with as a glaucoma case, angle closure management, normal management, and then we defer the phaco for another session or something after controlling the pressure. That's my understanding.
Okay, this is a combined. Maybe it could be a combined.
Sorry.
No,
maybe you don't want to do it as a combined surgery. Yes, Dr. Ala, sorry.
Oh, yes, Dr.
Can I have it? Yes, Dr. Ahmed, but I believe I differ with you. أختلف اختلافا تاما.
Yes.
Because in such shallow anterior chamber and long-standing glaucoma, if you will do it trabeculectomy or any sort of glaucoma surgery, you will end with lost anterior chamber, and really it was the hell. And nowadays, no, the rationale of removing the lens in such narrow angle is worldwide. You are opening the angle, and most of these cases are responding to phaco. And the question, but I don't want to lose your time, either phaco alone or phaco trap, because such cases can be for 3 months or 4 months, for example. I used to do phaco trap for such cases, but after a discussion with Ike Ahmed, actually, and this was in Dubai, actually, this was since maybe 2 or 3 years, and I returned back, and in such cases, I am doing only phacoemulsification.
Yes.
Here, Dr. Safwan, I believe you were with me. I have given mannitol on the table.
I agree fully, Dr. Ala. I'm with you in step, and I agree fully with you what you are saying.
Thank you very much, and I agree with you also because I started with what you have just said, that pars plana vitrectomy. Dry pars plana vitrectomy.
Stop here, Dr. Ala, but you measure 4 millimeter here. And those cases, just stop it, please, if you don't mind.
Yes, I'm trying.
Yeah. Here, the problem is that those cases is hyperopic, and their pars plana is not a 4 millimeter. Their pars plana is a 2 millimeter. So,
Dr. Safwan, yes,
I will answer. Dr. Ala finish.
No. Just Dr. Safwan has raised a very nice question. But this very narrow pars plana is present in only those with anteroposterior diameter. The axial length is less than 19. By definition, the non-ophthalmos. If you look to this biometry, it was 22 point something, meaning that the axial length was as in 85% of these hyperobes, alhamdulillah, that they are okay. The pars plana is okay. I have measured 4 millimeters because in such cases, if you have less than 19, Dr. Safwan, I agree with you fully. And this is very serious to do pars plana because maybe pars plana is even absent in such cases, the non-ophthalmic cases. But this was not a non-ophthalmos, Dr. Safwan. And the biometry, if you have seen it, that the biometry was a normal one, actually. I will continue. I have done pars plana vitrectomy, and usually it is done dry, meaning that just very short cuts, just to diminish the tension by the blade, super blade. I have done my incision, and then doing the dry vitrectomy, and look that the eye will be softened a little bit.
Yes, exactly.
And there is something that I learned from here.
Yes.
I learned that now, when I am trying to do my incision, it's very difficult because of this softness. And that was much better nowadays that I am doing, not the main incision, the side port, in order to fill in this. Here I have entered, and thanks God that it was possible to enter with the viscoelastic. Just I am filling the anterior chamber again in order to be able to complete my incision. But take care, in soft and such soft globes, it's very difficult to do your incision. Here, because incision is okay, and I believe that in such, this size of pupil is okay for me, and I am doing my rexes slowly but surely, and I will do my preferred technique actually. In order to save time, maybe I will go more and more. There was no problems in doing my usual technique, the side ports, and then I am fond of divide and conquer, Jama'a. And I was using phaco chop for 7-8 years of my beginning. I have began phaco maybe 1999, and I started by shopping. Actually, I was very fond of Nagahara technique, and then I have shifted to divide and conquer, and since I have shifted to divide and conquer, I am still on divide and conquer. It is very reproducible and a very safe technique. I have done my hydraulic section. I am found that I must do rotation of this nuclei before doing my phaco, and then by doing my phaco in the usual manner, which is divide and conquer, my usual technique. Actually, you should know several techniques, of course, and the technique of Dr. Ahmed that he have just shown, I will try it maybe once, or maybe it's okay, but I am fond of this technique.
Enjoy it.
Wallahi, thanks, Ahmed. I will try. We have to try, actually. And we have to learn to know more than one technique. After finishing, there was some posterior capsule remnants, fibers on the posterior capsule. And usually I'm doing it. Here I'm doing gonios and nucleolysis. Using the viscoelastic, I'm just injecting it sometimes with the spatula. Exactly. Last week I was doing it with the spatula, and a minute bleeding happened with me. This was right since few days ago, but this is usual. Don't be afraid. By just injecting viscoelastic, you can manage quite easily. Here I'm removing the fibers over the posterior capsule, and then I'm putting my IOL, and then I will do irrigation, aspiration, and hydration as usual. I will go. This is the post-operative day one.
I can small comment, please.
Yes, of course. And I will just, Dr. Ahmed, just wait for one slide, and then I will open it for discussion. This is day one, and this is day 5, and the tension has been controlled to 14, and you have look for the anterior chamber depths, that everything was okay. And what are the messages from such a case? Risk of pupillary dilatation in shallow anterior chamber, of course, you have to look over it. Management of non-responding angle closure glaucoma, usually it is phaco and phaco alone, and this is giving me, and all over the world, of course, giving me a high rate of success. Mannitol pre-operatively, the amount 120, 150 millimeters, and timing, just half an hour before doing your surgery. Don't put mannitol several hours before entering to the theater because it acts very rapidly actually. And you have to put mannitol. Actually, I'm admitting into the theater, and just beside the theater, I'm giving the mannitol. Anesthesia, if I can do general anesthesia in such cases, of course I will do it because there is manipulations, pars plana vitrectomy, as you have seen, and the surgery is routine, and the role of goniosynovitis, and it's open for discussion, Dr. Ahmed.
Yeah, I agree with you. It's very good surgery. But I have a small comment about making first side incisions or to go first for pars plana vitrectomy. First, what we are doing, we have like 2 weeks ago, the same case. We are inserting the trocar first. And after that, we are going for side incisions. Because if you are starting from first side incision, I mean with the cataract incisions, we will have very soft eye, and it will be difficult to insert our trocar. If we are using our trocar and we are start to aspirate vitreous, we will have very soft cataract, and it will be difficult to make our incisions. First, what we are doing, the trocar, and after that, we are going for side incisions, and after that, we can aspirate, we can go for pars plana vitrectomy. That's it. I mean, the different, yes. That's it. This is my comment.
Nice. It's
and
nice.
How, which better to use, first to use.
That's nice. I believe the message is here. Angle closure glaucoma due to it's managed by cataract alone, and this will give you a very good result actually.
So just one.
Thank you, Dr. Ahmad, for Dr. Ala for this case. If you can go to the second case.
Yes, please. Yes.
Yes.
My second case, and please, it's a routine case. Male, 65 years old, no systemic disease, right nuclear cataract 2+, straightforward surgery. And sometimes we have such cases as a routine. The axial lens 22.9, anterior chamber very nice 3.6, and the cases are somewhat steep, but it's okay, and the IOL power 20, and there is nothing wrong. Actually, I have started, and please, this is my usual routine, through the main incision on my right-hand side. I am doing my usual rexes. I'm starting by the cystotome in the middle, initiating the rexes, and then using the capsular rexes forceps. I am doing almost 5 millimeters rexes usually, and in the usual way. This is a very nice red reflex actually, and there is nothing wrong. And I was very relaxed in doing such case, and then doing my side ports, one on the right-hand side and then on the left-hand side. And then I proceed to hydro dissection, my usual hydro dissection, just entering under the anterior capsule, raising it a little bit. And if it is, I must do the rotation, and then I will start my phaco. My phaco is my usual divide and conquer that I am fond of it. And everything looks fine, everything looks okay. I'm doing my divisions, and then I am taking my first quadrant, and then the other quadrants will come. Sometimes there is tumbling, but if your instrument is okay and your phaco machine parameters are okay, everything will come to you in your place, and you don't have to search. Look for my right-hand side, it's always in the middle. Just have a look here, please, during irrigation aspiration, and try to concentrate. Because at that time, I was not so concentrating. It's such an easy case, and we are going to finish, and the nurse is putting the IOL in the cartridge and everything. Here, just I was not, it happens that I don't know where is it, where is the entry, where is the entry? Yes, it's here. Yes, it's here. And I entered, it's okay. Up till now, I was not knowing that something happened. Look for that. What is this? Another time. Look from here. Look. What is this? What is this? What is this? What is happening? I will try to stop. Any idea, Gama?
Yeah,
what
this
happened?
This posterior capsulative.
Yeah,
just
tackle, and that vitreous tackle, because you went out the chopper without supporting the capsule, the posterior capsule. So I think that that's the main issues in
a rent in the posterior capsule. Any other idea? I will put.
I don't think I cannot see actually a rent in the posterior capsule. I'm not sure this, Doctor.
Can you make it move, Doctor?
Because I think it's not clear for me actually.
Just have a look at this step. Look here. I am putting the irrigation. Just see what will happen now here. Just have a look. I will put it again. Yes. Just I am waiting. Just have a look of what will happen just now.
Okay.
Just now. Just have a look. Have you seen that?
This line,
This is total decimate detachment. Decimate detachment. How to manage now? At that moment, up till now, I was not knowing because I was not looking to the video. This is a video at my ease, but now when I am doing such, the deciment is bulging in the anterior chamber, and this is a total decimate detachment that happened from the irrigation. And this was the first time that I had such complication actually in my hand.
Yeah.
What I was trying from left to right, from right to left, it's okay. I succeeded to do from here under viscoelastic. I tried. At that time, I realized that there is decimate detachment, and the only way is to keep this decimate membrane high up against the cornea. There is sounds.
Yeah, please, if everyone can mute himself.
Yes, and from the other side, I am doing. I succeeded finally to remove this cortex with difficulty. Actually, my idea was that I must have the helon inside, and under this helon, just near the back of the capsule, I was entering and at once capturing this in order to get rid of this. And then finally, I succeeded to remove the cortex and filling with viscoelastic. Look here, while I am just putting here, there's something, another detachment happened. Did something look for that? I was just putting helum. Another detachment happened. Yani, there is a major detachment here, and another detachment happened here. It's okay. I have put my viscoelastic, and away down the last piece of cortex. And then I will fill deeply the anterior chamber with viscoelastic, and I will put my oil. And finally, what do you propose all?
First of all, as I told you, just if you allow me, first, you entered. Now before that, when you are removing any instrument, for me, I'm supporting the anterior chamber. Now, by supporting the anterior chamber, you will not have this problem at all. But when it's happened, and you need to implant, in my opinion, I need to go through. I will return back the decimate membrane again by entering air, and before implant.
Why
before implant? Just return it back, draw the air again.
Well, the helon, Dr. Safwan, the helon has done the job. Actually, the helon has pushed the decimate membrane.
I try it. It happens with me because it's happened with other. That's why I'm not leaving the anterior chamber without viscoelastic. So it happens with me. So I try it with the viscoelastic. It returned back, but when I try to implant, I still seeing the tag of it. It's tackle with the lens. So I tried. Then I put air to push it up, and then I push the lens in. So
okay, yeah, this means that you are putting.
Dr. Safwan, when you are going to put the intraocular lens and the air is there, it will go out. So
no. See what's happened is that I put
he's putting viscoelastic and he make it all full, so it will push all the.
If you wait for me, Muhammad, if you don't mind. What I did is that I put air, and I'm sure that the detached decimate membrane return back. Then I draw the air, and no, change the air by viscoelastic. So here
Okay.
I'm sure that the Decimus membrane return back in a proper way. Then I implant, even though.
You mean, Safwan, that you don't want maybe to go on the top of the cement by viscoelastic. You are afraid of this one.
That's what I'm saying. I use the air, return it back, and then I change the air by viscoelastic, and then I implant.
So, okay, Dr. Safwan, I believe that's a very nice idea, actually. You want to be sure that the Decimus membrane has returned to its place before inserting the IOL.
Exactly.
My idea that I was just appreciating that there is a very good space between the posterior capsule and the Decimus membrane, actually. And I was able to put my lens, and the message here is just to leave your case with air. And this is the next case. That's day number 1. The air is still inside, and this detachment has, and this is after 6 days, actually. And this is the same patient, everything looks fine. The most important is to know the complication and how to deal with it. Actually, it was my first time to have such horrible Decimus membrane detachment. I don't know why it's difficult for the cornea surgeon.
It can happen everywhere. Anyway,
Yes.
Dr. Ala,
thank you, Dr. Ala. Thank you very much for this.
Just Dr. Muhammad, one thing to comment here. Issues is that post-op, I'm trying now, I'm doing post-op for all corneal edema, post-op, I'm doing anterior OCT to see if there is any separation of the Decimus membrane, that it might happen during the surgery, and I didn't notice it. So it happens twice with me, and I found that this anterior OCT shows clearly that there is a separation, and I return back the patient back to inject air, and I didn't wait for a time for the cornea to return back. So anterior OCT in a corneal edema is a one of the important issue post phacosurgery.
Yes.
Thank you very much, Dr. Safwan.
Please.
Okay. Now we can have, okay, Dr. Ala, I think you finish this case. That's right. We can go now.
I can go on. Okay. Yes. If Dr. Muhammad Al-Amri will allow us, you know, he is the moderator.
No, Dr. Ala, you can go ahead. You have another case?
Okay.
You don't hear me, I think.
I will omit this case. Maybe I will go to the next case.
Okay. We have to see
my case is a male, 56 years old, non-descent disease. This is the case of uveitis, and he has poor vision since a long time ago. And he was Mudir Madrasa, actually, nearby Alexandria. His visual acuity is 160 right eye, 160 left eye. The eyes were quiet when I examined him. There was actually cells in the right eye 2+ and left eye 2+, nuclear cataract, and point of explanation is subluxated or not. I was not sure.
Please, I need everyone to mute himself. Everyone, all even panelists, all panelists.
Okay. Okay. There was very hazy media, and the cup disc ratio was 0.8 in the right eye, 0.9, because the tension in the right eyes was 47 millimeters mercury, and the tension in the left eye was 14. What shall I do? Now the case, there is active uveitis with cells 2+ and nuclear cataract, and there is risk of subluxation and cup disc ratio high, and the tension is uncontrollable in spite of medical treatment. I have given him anti-glaucoma and steroids, and tension was uncontrolled. It was 36 in the right eye. The left eye remains, it's okay. And during my follow-up, a hypopyon happened in the other eye, in the left eye, which is the eye with 14 millimeter. But what shall I do with the right eye? Uncontrolled tension, his vision was 160. I stayed with him for about 3 months. The iritis or the uveitis has been controlled a little bit, and I decided to go on. I have tried to do right cataract operation for him. After dilatation, look, I am doing my main incision. Look here what will happen during even the helon. This is I have done a stain also, because there was a posterior subcapsular cataract, and I told myself that it's better to do a stain in such case. Maybe I will need to see to visualize the anterior capsule. Look here. A subluxation is seen again. Look here while I am putting the viscoelastic. Look, a severe subluxation. Okay, what shall I do? I prepared my retractors. At that time, I haven't prepared the capsular hook, and I told the nurses to prepare the iris hooks. I started my rexes, knowing that there is some subluxation, but to which extent, up till now, I don't know. And I have done my rexes. It's okay. And I'm doing it spiral funnel. Spiral meaning that I've started, as you have seen, a little bit smaller, and then adding viscoelastin and finishing it whenever the size is okay. And this, I believe, I am applying it to most of my cases here. It's okay. And I believe this size is okay for me. And I'm preparing for the iris hooks. Iris hooks, I will use them as retractors for the capsule in order to be able to finish. And then, in my opinion, or in my back mind, I was preparing myself to CTR or modified Sione with, and I tried my phaco. This is after putting 3 of the iris retractors, and I have tried hydro. The cataract was not hard, actually. And that's okay, my usual technique. I wonder, Dr. Ahmed, if you can do this posterior anterior shopping in such case with subluxation. But here it's okay, very slowly, very cautiously. And then I have put a 4th one, meaning that I have 4 iris retractors, and then I'm doing my usual Pardo divide and conquer very slowly. This is Osher technique of having very slow phaco with very low parameters. It's okay, there is nothing happened up till now, but what will happen? Yani, what? The cortex will be a main problem. And up till now, I don't know the extent of the subluxation. That's why I tried, okay, before doing the CTR, I'm always deferring the CTR to the last possible. But whenever, look here, what, I discovered that the whole lens is coming with me. The whole lens, meaning that it was here and here. What's about here and here? Also, I told myself to give it a try, put adaptive viscoelastic there to prevent anything, but actually I'm trying to get the cortex. But I believe that here the lens is very well seen that it's subluxated from this area also. And I discovered that the subluxation is almost 360 degrees. And what shall I do in such condition? I have decided with the retractor to remove everything. And as you have seen that it is really, there is nothing. Yani nothing is left, maybe up here, maybe, but there is no, it was subluxated almost 360 degrees. At that time, what to do? I am removing everything with the cutter. And now for the IOL. What shall we do? Actually, at that time, I was not doing Yamani technique frequently. And what I have chosen, actually, Yamani technique in such condition is actually perfect. I have chosen to put an iris flow IOL. That's carbachol was put in the anterior chamber to constrict the pupil, and then slight widening of the incision. And I have put iris flow because I have a good experience with iris flow. That's the phakic IOL. I use it a lot. And I am putting it here and fixing it anteriorly. You know quite well that you can put it anteriorly and posteriorly. Here I have chosen to put it anteriorly in order to avoid more complications if it will fall in the posterior segment. I have fixed on the right-hand side and then doing inclination on the left-hand side. And then I will take my sutures. I will be taking my first suture and then my second suture, doing hydration, and this is the case. That's 6 days post-operative. That's the case. I have done at the end a peripheral iridotomy. Don't forget with such lenses to do a peripheral iridectomy. Here it's somewhat large, but it's okay, it's functioning well. And with 2 sutures, there was some astigmatism. Of course, thanks God that it is only 2.5. Usually it is much more than that. And he was reaching 0.1, and the tension is controlled. And in the follow-up, his last visit, that was in February 2019, that was 1 month post-operative, he was 0.2, tension was 20, and he was on systemic prednisolone to control his BSED, OptiPret, slow tapering, and some Twinzol was added, but he was happy. And up till now, he hadn't done the other eye. What's your opinion, and what to do in the next eye?
Yep. A very excellent case.
Thank you, Dr. Ala, very much for this excellent cases. And I think there is a question you have made to Dr. Imad, and he is now going to answer, because I know Dr. Imad already he present one case with subluxation, and he fixed with iris hook, and he managed to do it by his technique. But Dr. Imad, if you want to comment.
Yeah, the question here, it's very good decision the doctor took, because we have 360 zenules lost, and in this case, no chance to fix it, no chance for any fixation for the bag. The good solution is to remove everything, but in my case, I have subluxated lens. It's in one part of the eye. We are talking about maybe from 6 to 12, and in this case we can keep the capsule, we can put tension ring, and we can continue our irrigation aspiration of the cortex. But in Dr. Ala case, as we see 360, we have bad zenules, and this is a good solution to remove everything. And
thank you, Dr.
We have a little different, with the
Dr. Muhammad, please.
Okay. Can we have? But please, if we can manage to give a very short comment, or this one, because we are already behind the times. Okay.
When we are saying 300, definitely Dr. Ala, his technique was perfect. But what about the Sioni with a double ring? Now, double hole for the fixation. So what we are doing here, the bag, as I saw, it's the main issues is that the zonules, it's from a lot of sites is lost. Now, in this situation, if we are succeed to go in and insert a Sioni or double Ahmed piece, here I prefer Sioni with a double ring and suture it to the sclera. Now, someone will say that we have a Yamani technique and we have a scleral fixation with Jortex, so why you need to do? All the published studies shows that a lens in the bag is better than creating a scleral fixation or any other lens, especially that case having a uveitis. So in my opinion is that, or that's what I'm doing. I'm doing Sioni with a double and suture it to the sclera.
Thank you, Dr. Safan. Any comment, from Dr. Ala? You have to unmute yourself, Dr. Ala, because you are okay.
Now I am unmuted. Yes, okay. Thank you very much, Dr. Safwan. Actually, great, and I agree with you. What you have said in double Sioni is very nice, but actually it was not available at such condition, and this what was available for me. But what you are saying is exactly perfect.
Yeah, but if you have it, and if it is available, then it will be a good choice to solve this problem.
It's perfect.
Dr. Ala, you have already shown us a very interesting and different complication and how we can manage.
Can we go for one last for the road, maybe one last case?
We have many questions still, Dr. Ala, to answer. If we can answer the question and there is a time, we can go that if you don't mind.
I will stop share.
Yeah, please.
Okay.
We have many questions, so we can go to this.
Very good.
When do you decide that this is a question for Dr. Ahmed and Dr. Prasan, as Dr. Ramin, he left us because he's having another webinar. When do you decide that anti-VEGF has failed? After how many injections, including DMA, before you choose to switch another class of intravitreal treatment?
Sorry, come again. How long, sorry, doctor?
Yeah, after how many injections?
How many injection for
yeah.
DME, right? We are talking about
Yes,
DME,
yes,
right?
yes,
Yeah,
yes.
yeah. Okay. So it's it's a debatable point. Sometimes if you attend the meeting, you do 6 injection, 4 injection, 5 injection, whatever. But what I understand, what I'm following actually now is the post hoc analysis of protocol. I like it so much because it gives you a clue or prediction that after 3 monthly injection of anti-VEGF, you can decide which kind of patient will be. For example, if you have more improvement of more than 20% in terms of central macular thickness or more than 10 letters, those patients are most likely to respond well and continue the same for a long period of time. But if you have a poor responder after 3 monthly injection, you are now in 2 ways. I cannot say there is something wrong or something right. It's a gray zone now. What I'm doing personally, I start to switch early, especially if I see some signs of inflammation in the OCT, like hyperreflective dots or subretinal fluids. Any signs of inflammation there, I switch early to steroid. I don't switch between anti-VEGF and DME. And I have evidence base for that. We don't have any trial to prove that until now. And most of the trial was a small number of patients. And if you look at the result, it's contradicting each other. So I don't think it's wise to waste your time and to try to switch another anti-VEGF, take another 3-4 months of injection. At the end of the day, you are not sure about how the response. So if the patient take 5 or 7 injection of anti-VEGF and they still respond, so it's better. So I think it's depend on case by case.
Okay.
But I think the message here, don't switch between anti-VEGF and DME. That's my
thank you, Ahmed. If you allow me, all dear respected panelists here, if you can give a very short answer, because we are already very behind the time.
Okay.
There is a comment about Dr. Imad case that it cannot. We need a large rexes and must dislocate the nucleus outside the back. I think we have comment about this one. It is not. By experience, I think it will be more. You can use it even in a small pupil and small rexes. Is the side board should be opposite to main incision? I think Dr. Imad, your incision, it will be, as you mentioned, one is in the 10, the other one is to a 9, and you already mentioned this one.
Yes.
Very good, Dr. Imad, good work, and also Dr. Mikhail. This is for a comment from Dr. Nadim Al-Hussein, my dear friend. How can we get this spatula, Dr. Imad? These many questions came now. You see, now we are very popular.
I think the spatula you can buy internet, request it. Maybe.
Okay, I think Dr. Imad, if we can get a special things, then we can send it by WhatsApp and in email to all those.
I think you can. It's available in the market, and you can ask any companies who is dealing.
I mean, do you have a special company they can buy from that?
Our spatula, I bring it with me from Russia, but this I don't know really. But I think it's not that difficult to get it, because
we have a comment from Dr. Osama Al-Jlaidi, our dear friends. Thanks, Dr. Imad, great talk. I feel it's a more difficult in a small pupil. I think you already comment about what more risk to induce meiosis as more touching to the iris. The position of the two hands is away from each other, make it more difficult than what we are doing. I think it's already you have tackled this, Dr. Imad. Okay. Question about the first presentation, after how many injection of anti-VEGF? I think this one already we answered. If the patient is diabetic, do you still give mannitol? This one in the case of when we are having a glaucoma. Dr. Ala.
Yes, I believe 120 milliliter of mannitol. What will happen for them? We can nothing.
Nothing.
Yes, you can. It's once. It's not. Yes, we can.
Okay, there is a question. I am concerned about using iris fixed IOL in uveitis eye. Prefer scleral fixation. This is, I think, about the last case you present, Dr. Ala. Your comment?
You are muted, Dr. Ala. You are
Dr.
muted.
Ala,
But I am not muting. Somebody is muting me. Okay.
I think our company, because we are hearing a voice of children from your place.
No,
That's all.
nobody around me, right? Actually, nobody. Okay, I am of the same concern, and I agree fully with that doctor. Very nice. That yes, there is a concern of these lenses in uveitic patients actually, and the best solution is what Dr. Safwan has told: the double Sioni and keeping the IOL away from the uvea inside the capsule. And that's what Dr. Safwan has said is the best. But actually, sometimes you have what to do with what you have, what tools you have to solve the problem. Up till now, there is nothing. But yes, I agree and I appreciate that.
Yeah, I think now we are having a different way to do a secondary. If you score it now after removing everything, then you can think about it as a secondary IL fixation, as Dr. Safwan and Dr. Ala mentioned, either Yamani technique or scleral fixation. And I have seen the one which one is more now is they are using to fix the bag itself with a ring. That's that Dr. Safwan mentioned the name. I think the other rule is the same. They are talking about uveitis is not desired. And in uveitis IOL, all the same are mentioned already. We have talked about these questions. All the questions are now answered. We are having Dr. Lama, if it's still there, if you want to ask the questions. Dr. Lama, I think if she is there, or John. Otherwise, I think we are already, unless if the our panelist wants Dr. Ala to give his last case. I think still the people they are start to go out because of the time of sleeping, but we can have your case, Dr. Ala, the last case.
Can you see it now?
Yes.
She's a female, 55 years old, one eye. The left was atrophic with no PL since long time. Her vision was hand movement with good projection. What is astonishing, there is a microcornea and there is a large coloboma of the iris. There was nystagmus and total brown cataract. What shall I do? I did ultrasound. There is some minute vitreous opacities. There is also choroidal coloboma with the iris coloboma and some cystic components behind, but nothing wrong with the retina. The retina is in place. Regarding the biometry is okay. The axial length is 22.7 and the K is 41.43 and the IOL in the usual range, 23.5, and everything was looking, it's okay. But what to do? Such a case with microcornea, black lens actually, and this is the surgeon view. What shall I do? Shall I go for phaco? And there is this position. What shall I do? I decided to go for extracapsular actually.
Can I interrupt you, Dr.
Yes, of course.
What do you think, Dr. Safwan, if this is your case? Are you going to do what? Phaco or you'll do extra cap or what? No, you are muted. Can you unmute yourself, Dr. Safwan?
See, as I said before, me and Dr. Ala, we shared a lot of chemicals in between us. So
it is the same.
We are on the same line. So I don't need to, the same what he did. It's an extra, it's a case of extracapsular cataract extraction.
Okay, thank you, Dr. Safwan. Go ahead, Dr. Ala.
I lost it. It's okay. And here I have opened the incision and usually I'm not using scissors. This I will go more rapidly in order to the usual extracapsular cataract extraction. Nothing wrong up till now. I am widening my incision. Yes, it's okay. I am doing wide incision and then I am in order that I anticipated that this lens is huge, and I have done a peripheral iridotomy and changing it into total one in order to have a way for this huge lens to go out. And then I will do pupilloplasty, that I will close this pupil by suturing it. And I have started my extracapsular in my usual way, doing can opener technique. Yes, and the lens is very hard, moving a little bit because it is a black cataract actually, but it's okay, nothing wrong up till now. And then I'm getting the lens out, which is an easy step, but to my astonishment, it was impossible. It was impossible actually. There was no vitreous pressure. What shall I do? Tell me, what shall I do? No vitreous pressure.
Well,
the loop, the loop, yeah, the loop that Dr. Ala, you have a large loop, and
yes,
we have a different loops. So maybe the small loops to go behind the lens and pull it, especially if you are using the envelope. I think that I heard you that you use the envelope technique, right?
Actually, here I have done the can opener technique.
Can opener.
The usual can opener.
Yeah, okay.
Actually, yes, this is a large loop, but I was aiming just to get it in the usual way.
Yeah.
And for maybe 15 minutes, I was not able to get this lens out.
I do agree.
What I have decided.
Yes.
There is a way if you can push a helium behind the nucleus.
It was extremely soft, actually, Dr.
It is not hard.
The lens was extremely hard. I meaning the eye itself. I was not.
The eye itself. Okay.
And I would like to put the helium where I can see it. Actually, what I have done is that actually I will show you. Okay, it was not possible at all. And what I have done, pars plana and PAL technique. PAL technique is posterior assisted levitation.
Yes.
I have done my incision here about 3.5 millimeter behind the limbus, and then using the spatula to go behind this lens and to push it in the anterior chamber and to get it out. And remember, this is a case one-eyed, nystagmus, coloboma iris, coloboma choroid, and really I was very concerned about her. What shall we do? Here I am manipulating this nucleus in order to get it out and then getting it in the anterior chamber. And with the help of the assistant, he will get it with the cystotome just outside. And look how the air has entered inside, because it was extremely soft, extremely soft. I have just put my sutures, and really at that moment I thought, what shall I do? And also you have to think about Yamani techniques here, fixation, look for the nucleus. Actually, I decided not to do anything. And this patient was having hand movement since maybe 10 years. And just I decided to do like that. And this is the next day, air inside the anterior chamber. And after a while, this is the picture with the 5 sutures. And you cannot imagine the patient was happy. And I have corrected her with aphakic glasses, of course. But actually, she is visiting me since 4 years now, or maybe 4.5 years, with the aphakic lenses, and she's going on. She's okay.
What is the visual acuity, Dr. Ala, for this patient?
With the correction, it's about 460 actually. She has nystagmus and she has coloboma iris and coloboma choroid, and this is the maximum that we can achieve actually in such cases.
Yeah.
Thank you very much, Dr. Ala. I think
you are most welcome, my dear.
Any comment from Dr. Brasan, Dr. Ahmed, Dr. Safan?
Well, just Dr. Ala, he knows that he is a pioneer in the open an envelope technique, and I think that I learned a lot from him for the envelope technique. These are issues that we were using it, me and him, and we are in the same club. We are in the 50s, and I think that Ala, he's a little bit,
No,
Yeah,
Dr. Ala is 45, 45, 45.
No.
I think you
Anyway,
are doing
so
something
in
wrong.
envelope, yeah, an envelope technique, an open envelope technique, we can open it, and there is a posterior capsular support and anterior capsular support. So here, if we can inject the viscoelastic in it and then go under with a loop, that loop should be smaller. It's for the pediatric, and then push, draw it out, and it will be easy to draw. But the technique that he used, and he's a pioneer in that, is easy. And at that time, as he said, sometimes at the moment of the problem that happens, what's available around us, we need to use it. And we need to think for a while of time what to do, but the available things. And he thought in a beautiful way to go pars plana, through the pars plana, and push the lens through it. And it was a black, this is a cataracta nigra, what we are saying, and it need extra, and his technique was absolutely the right way.
Thank you very much, Dr. Safwan. Thank you, Dr. Ala. Thank you, Dr. Imad. I'm proud that we are the first people that we announce about your technique, and it shows that it's a very excellent technique, and maybe
thank you so much.
For new generation, it will be something to add. And also thank you for Dr. Ahmed Al-Barqi, Dr. Brasan Ram, Dr. Arif,
pleasure.
and also
Thank you.
for Dr. Raman. He left already from us. It was a great, the plan, it was 1.5 hours. You can't believe it. Now we are 3 hours, and all the people stay with us. That means it was an interesting, and all they are listening and they are interacting with us. I appreciate your times and your experience that you share with us. And we hope to see you, inshallah, in another webinars. Thank you for Alimera for sponsoring this meeting. Thanks for management events by the Vision, and special thanks for all participants. They continue with us till this time, and we hope to see you, Dr. Ala. Really, I am glad that you are with us. Thank you, Dr. Iman. Thank you, Dr. Safwan again, Dr. Ahmed.
Thank you.
Thank you.
Thank you.
Arif,
Thank you.
Thank you.
Bye.
Thank you.
Thank you. Thank you. Bye-bye.
Thanks a lot.
Bye-bye.
Bye-bye.
Thank you.
Stay safe. Stay
Thank
safe,
you.
everyone. Bye-bye. Bye-bye.
Thank you.
Dr. Muhammad.